KEYNOTE 10 was first presented over 3 years ago at an early readout. It was published in Lancet. Now we have almost 4 years of follow-up, so 3 more years of follow-up. And what we've been able to show here are a number of very exciting things. First of all, in this trial that looked at Pembrolizumab, a PD-1 inhibitor, versus docetaxel in refractory lung cancer, we see that at 3 years, we now have in the PD-L1 1% group an actuarial 3-year survival of 23%. And in those patients with PD-L1 greater than 50%, that number is 35%. So clearly the durability is there, and it shows the selection factor of PD-L1. So toxicities, no different toxicities than we saw in the short term, meaning that these drugs were safe. And then the other thing to point out is that 79 patients received PD-1 inhibitor Pembrolizumab for 2 years. So we looked at that group of patients. And as you would imagine, almost all of them had response, a few CR, most of them PR. But 35 weeks of treatment, 35 cycles of treatment occurred. And we looked at those patients, and actually, since we've been following them, 14 patients now have recurred. So one of the things we asked in this ESMO presentation was what happens to those patients when you retreat them with Pembrolizumab. So we've done that, and actually 6 patients of the 14 actually received Pembrolizumab and responded. So we've seen responses now when we retreat, and 5 out of that group had stable disease, and a few did not benefit. But there were no untoward toxicities seen in any of those patients. So it suggests that we can use the drug again in those patients who go out for a long period of time and then become refractory.
I can tell you've gone through this before, but that covered a lot of the notes and what we wanted to hear. I guess the main questions now are looking at the legacy of what this trial means for patients with non-small cell lung cancer and what's being done to take these results forward and see what else is happening in the space.
Well, this trial, really the first randomized trial to prospectively look at the biomarker, the 22C3 PD-L1 biomarker. So by having these data, it then informed the first-line data, the KEYNOTE 24 and others. And of course, now we're using Pembrolizumab in the first-line setting in those patients who have PD-L1 greater than 50%. So that's one legacy of this trial. The other now is we know a little bit about these long-term responders. So I would suggest that now we can take the samples, the DNA and the tissue that are banked and available, and try and understand what is it about these patients who did so well that differentiates them from people on the trial who might have done quite poorly, and try to understand early on who's going to benefit most. A lot of it is PD-L1 status, but it's not going to be the whole story. I think we're going to be looking at things such as tumor mutational burden. We'll be looking at presence or absence of tumor-infiltrating lymphocytes, the quality of those tumor-infiltrating lymphocytes. So that's something that we can probably gain insight in from analyzing specimens from this trial. Also now we can better understand the response, why people are responding or not. I would suggest that in the second-line setting for immunotherapy, and I would suggest that someday we'll be biopsying people when they become recurrent, and we'll do personalized second-line immunotherapy. And actually that's going to be critical, because as I walk through the ESMO meeting, there's so many posters and presentations about new doublets and new ways of targeting the immune system. And we're going to have to sort of personalize that, just like we've personalized immunotherapy to begin with, and also targeted therapy. And I think we'll do that by getting biopsies and using those biopsies to then put patients on the right drugs at the right time.